There it goes. P wave at every complex. Is there a P wave before every QRS? How many P waves are there between each QRS? Look at the T wave. Is it the same direction as the QRS? These are all things to start looking at when it comes to rhythm. Okay, is the rate regular? Are the QRS complexes happening regular? Are the P waves regular? This is where you do all your rate analysis. Then you move on to axis. What is the axis of this 12-lead EKG? Remember the thumbs up method. Left hand is lead 1. Right hand is AVF. Look at the QRS complexes, and we'll review all this in a minute when we go through the slide. Lead 1 is left thumb. AVF is your right thumb. We'll go through it in a minute. Then you look at your hypertrophies. Look at your QRS complexes. Look at the P waves. Know the difference between left atrial and right atrial hypertrophy. What's the change in the P waves? What happens with the QRS complex? And then finally, injury. Looking for pathologic Q waves. Looking for ST depressions, ischemia, those things. That's the injury part. So that's the same method. Use it every single time you look at a 12-lead EKG. What's the rate? What's the rhythm? What's the axis? What's the hypertrophy, if there is any? And is there any injury? That'll give you everything you need to know about EKGs. Okay. So again, this one only works when you do it in presentation mode, or else it won't make any sense if you're just scrolling through it yourself. Okay, so let's go over the basics again. So what is number 1? Okay, what's number 2? PR segment. What's number 3? PR interval. What is 4? That's your Q. 5. What's 7 or 6? That's the whole thing. 7. Okay, 8. J point. 9. ST segment. 10. And then 11. QT interval. Okay, very good. Okay, what is the voltage or the vertical axis of one small square? Voltage going up, 0.1 millivolt. Every one little box, 0.1 millivolts. What is the voltage vertical axis of one big square? 0.5. It's 5 little boxes for one big box. What is the time, the horizontal axis of one small square? 0.04 seconds. And what is the time there of one big square? 0.2 seconds. Okay, what is your normal PR interval? Okay. You can also remember the PR interval should be within 3 to 5 small boxes. So you can look at the beginning of the P wave, make sure it's within one big box, and you know you're good. If it's wider than one big box, we know we have lengthened PR interval. So 3 to 5 small boxes. What leads are the precordial leads? V1 through V6. Remember the precordium. They start at V1, anterior part of the heart, more septal, anterior, then lateral for V5 and V6. What leads are the augmented limb leads? AVL, AVR, AVF. Those are augmented because they're augmented only one polar. What are your standard limb leads? 1, 2, and 3. Very good. Normal QRS interval. (80 to 100 milliseconds, or 0.08 to 0.1, or 2 to 3 small boxes. Okay, as long as that QRS complex is within 2 or 3 small little boxes, it's a normal QRS. And what does RAHI stand for? Rate, rhythm, axis hypertrophy, injury, ischemia. So the rate, what is the normal inherent rate for the SA node? 60 to 100. AV node, 40 to 60. Purkinje's, 20 to 40. What is the rate when the RR interval is one box? 300, right? Two boxes, 150. Three boxes, 100. Very good. Okay, so you can count them out that way if you want. Or look at the little tick marks. That'll tell you 6 seconds. Count them up, multiply by 10. That works as well. So how do you calculate the rate in bradycardia? Again, number of beats, 6-second strip times 10. What's the criteria for a normal sinus rhythm? P wave followed by a QRS. Rate has to be within 60 to 100, right? That's normal sinus rhythm. It would be rate normal. Each QRS, we mentioned that, preceded by a P wave. Normal P wave axis, upright in lead 1 and 2. Inverted in AVR. And PR remains constant. This is looking at your rates. Remember, looking at the PR interval, P waves, looking at all those things, make sure they're all normal rates for the intervals. And a narrow QRS. Okay. Axis. Okay, what two leads do you look at? One in AVF. Okay, what direction should they be? Both up, 2 thumbs up, is normal axis. So what's the value for normal axis? What's the degrees? So 0 to 90, remember the way that, it could be negative 30. That's where lead 1 is, right? What's at 90? AVF. There's your 2 leads. So if 1 is positive, we're more towards that way. Also, remember, if we have left axis deviation, that means the heart is tilted that way. Okay? Obesity can cause a left axis deviation as well as previous MIs. If they have a right axis deviation, the heart is shifting down, which you can see in severe, like anorexics, very, very, very thin people. The heart kind of goes downward because of the small cavity and everything. You can get a right atrial deviation with a very, very, very thin person. So make sure you understand deviation, what can cause different ones to go in different areas. What? 1 is at negative 30, but we can consider normal axis from 0 to 90. If you take a circle, break it up into 4 areas. So what's the yellow one? Extreme axis deviation. What's the green one? Left axis deviation. Your purple, or the right is the blue one, and then your normal axis. Okay, we just use those as easier ones because 1 is at 0. I'm sorry. AVL is negative 30. But 0 to 90 is your normal axis. And again, that's what it looks like. So if both are down, both thumbs are down, you're extreme right. If lead 1 thumb is up, AVF is down, only your left thumb is up, left axis deviation. Both thumbs are up, it's normal. If one's down and one's up, if the lead 1, wait, yeah, that's wrong. Yeah. Okay. I'll change this picture next year, because that's not right. Yeah, that should. So make that change. Okay, change that one in the bottom left to be AVF up, lead 1 down, yes.
So for the exam, is the normal axis going to be 0 to 90 or negative 30 to 90?
I'll double check that before I answer that, make sure that's consistent. Okay, so again, the whole 2 up, 2 down for the thumbs, this is the code. Okay, so this one, lead 1 is up, AVF is up. This is good, we're okay here. Everyone see that? Okay, lead 1 is mainly negative in this one. AVF is mainly positive, so this one is right axis deviation. In this one, lead 1 is positive, AVF is negative. This is your left axis deviation. And now they're both down, extreme right axis deviation. Okay, moving on to hypertrophies. What lead do you look at for atrial enlargement? Lead 1, 2 is a big one, but lead 1 can be used as well, but lead 2 is a big one. Lead 2. So lead 2 duration should be greater than 120 milliseconds, meaning it's a bigger area, takes a little bit longer for all that electricity to get across. Or V1, the amplitude, it's going to be very high because you're looking at atrial hypertrophy. They're going to get very tall because of the amplitude is bigger because there's more tissue. More tissue, more voltage. So right ventricular enlargement, where are you going to see these tall QRS complexes? V1, V2 is where you'll see most of that right axis hypertrophy. It's right here. Okay. V1, remember that ratio? It's got to be bigger. Or the R wave is greater than 7 millimeters tall for right ventricular enlargement. Okay, left ventricular enlargement, V1 and V5 or V6. Where are you going to see very, very, very tall R waves with LVH? V5 and V6. What should you see in V1? Deep S wave, because it's reciprocal changes from the anterior to lateral. Okay? So yeah, that Sokolow-Leon criteria. Again, look how deep that is and how tall V5 and V6 are. Okay, right, this is left ventricular hypertrophy because the left side of the heart is showing the changes. 5 and 6 are your left side of the heart. V1 and V2 are your right side. That's why when you start seeing bundle branch blocks, if it's a right bundle branch block, you see it V1, V2. If it's a left bundle branch block, you see it lateral, V5, V6. If they overlap each other, like there, it's a good sign that there's probably some hypertrophy going on. Not all the time, 100%, but if you see the complexes starting to overlap each other because you have a very tall R wave and a deep S wave on above it, they will overlap. And if you see that, good sign that you're seeing some hypertrophy there. Infarction and ischemia. What 3 things suggest infarction or ischemia? ST changes, right? We have to either go up or down. So segment depression, Q waves, so inverted T waves. When you see a flipped T wave, remember a flipped T wave means it's the opposite direction of the QRS complex. If the QRS complex is mainly positive, the T wave should be positive as well. Some conditions cause that T wave to flip. Or you can have a very negative QRS and a positive T wave. It's still the opposite direction. And then obviously your ST changes. So if you see pathologic Q waves, that means they've had an old MI. When you see Q waves, inverted T waves, ST segment changes are more the acute findings that you'll see at first, and then they kind of go away, and then the Q waves happen later. Okay, so what's the correct order of conduction? SA node, atrial depolarization, then the AV node, and then what? Bundle His, bundle branches, and then your Purkinje fibers. Okay? Okay, so P wave trivia. The first part of that P wave represents the right side depolarizing, and the second half of that P wave is the left atrium depolarizer and getting the excitation to cause the depolarization. Why don't they happen at the same time? Because we start in the right atrium and the impulse spreads across to the left. So the right goes first. So if you look at this section, normal, there's no hypertrophy, right and left, we're okay. Now look at right atrial enlargement. If you cut this in half again, look where the big peak went. It's on the right side. That's right atrial enlargement. So, okay, very, very tall P waves, peaked P waves, think right atrial enlargement. If you see an M shape, that's left atrial because here's the division, but the left atrium is bigger. It's a bigger chamber because of the hypertrophy. More electrical conduction, bigger voltage on the distal side of that P wave. And then if you have both right atrial and left atrial enlargement, you get both qualities. High amplitude because of the right atrium sucking up all that energy, and then the left atrium also being larger, so you have that M shape. So any type of P wave that is in an M mitral, it's also known as M mitral, it's left atrial hypertrophy. Peaked P waves, right atrial hypertrophy. Okay. Yeah, that's why I did all this. Okay, let's do some rhythms, and then we'll go to the quiz. Okay, what's this? Asystole, very good. Which one's this one? Look at, do your interpretation, go step by step by step. Okay, so what's going on here? What jumps out at you? The PR interval, right? Does everyone see that PR interval? What's happening to it? Lengthen, 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 drop. Then you have a Lenke-Bach, okay? Type 1. Okay, longer, longer, longer drop. Everyone good? Okay. Not AFib. Not A flutter either. This is VFib. This is coarse VFib. Okay, it's coarse because it's very coarse looking. Fine VFib is like this. That's fine VFib. This is coarse VFib, but it's still VFib. It's not atrial fibrillation. Why is this not atrial fibrillation? What don't you see? There's no QRS complex. In atrial fibrillation, the QRS complex is normal. Just the P waves are all messed up. These are all QRS complexes due to VFib. Okay, what's this one? Is it third degree or is this second degree AV type 2? What's happening to the PR interval? Is it lengthening or staying the same? Staying the same. But what happened? Random dropped QRS. So because of that, normally there's a P wave before every QRS except for one. We dropped it. If we kept this rhythm strip going, it would repeat itself over and over again. So, but we have a randomly dropped P wave, QRS complex. This is second degree Mobitz type 2. What is this? You said it right, Caroline.
Oh, okay.
What is it?
Third degree.
No, you said it first, right the first time. Oh, you said it. Oh, this is an atrial paced rhythm. I'm sorry, I heard over here, I thought. Okay, those are pacer spikes. Where are they happening? Right before that P wave. Why? Because it actually caused the P wave to even happen in the first place. If this pacer spike never went off, that P wave would never happen. This patient would go to asystole and wait for that next heartbeat to kick in. So this is an atrial paced rhythm. The normal conduction works. Once you have this pacer spike, this all follows normal. Just waiting for the next one. Okay, what's this one? Okay. This is third degree heart block. Why is this third degree? Do the P's and the QRS's talk anymore? Now, if you took calipers and you measured out those P waves and you marched them out, the P waves would be equal throughout. That's one good sign right there. P waves are constant. P wave, P wave, P wave. Okay? Everyone see those red lines I just drew? If you measured all those out, they would be even, which means the SA node is firing normally. What's happening to those QRS complexes? What do they look like? They're wide. Why are they wide? Because the ventricular rhythm is being generated by the ventricles. And when the ventricles generate a rhythm, it's going to be a wider rhythm. Remember, SVT versus VT. It's the width of that QRS complex that matters. You have tachycardic rhythm, but your QRSs are normal. It's coming from above the ventricles. It's an atrial rhythm that's causing this heart rate to go fast. If you have a wide QRS, the issue is the ventricles that are causing it because the pathway is altered. It doesn't look right, and it's coming from the ventricles. This is your third-degree complete heart block. There's no communication between the atria and the ventricles with this one. Be specific. Torsades. Does everyone see torsades? It's VTAC, but remember, torsades is a form of VTAC where you get twisting of the points. Okay, they change. That's torsades. What is this? Is this fast heart rhythm, slow, or normal? So we know it's tachy. Where's the rhythm coming from? So what is this? This is your VTAC. Okay? What is considered, how many PVCs in a row must you have before you're considered to be in VTAC? 3. After your third, then you're in VTAC. You can have 3 beats, 2 beats, it's just PVCs, couplets, triplets. But you start getting 4 or more, then it's non-sustained VTAC. And you can even write in your notes, they had a 27 beat run of NSVT. That's how many beats they had. If you are working in a cardiology wing, there's going to be an EKG tech on every floor. And all their job is they look at all the rhythms for all the patients on that floor. And they look at everything and they record anything that's abnormal. So if you're working on a cardiac floor, check in with the unit nurse. Ask, was there any changes in rhythm over the night? What was going on with this patient? Anything changed? Ask them. Okay. Do your rate, rhythm, what's going on here? Why is it AFib? A lot of squigglies and yeah. First of all, are the QRSs normal? Are they marched out regular? No, they're not. Can you even see P waves? Not really. Okay, atrial fibrillation. What is this one? A flutter, your sawtooth pattern. Okay, normal rates for A flutter are around like 150, but the atrial rate is like 300, 400, because only some get through. Here's your A flutter. Okay, what's this one? Say, it jumps out at you. That's why the more you guys look at EKGs, I gave all those resources and modules in your Canvas shell. You have to keep looking at these things. They'll point out at you. Look for rhythm, look for symmetry, patterns. That's how you can see things popping out very easily, looking for patterns. Yes, all that right there. There's your delta wave. This is Wolff-Parkinson White. What's this? Why is it first degree AV block? And what about it? Consistently long PR interval. And like I said before, here it is. You see how it's bigger than one big box? We know it's lengthened. Look at the big boxes. Okay. What is this? What's the rate? What? Fast. Okay, this is tachycardia. What kind of tachycardia is it? This is just normal supraventricular tachycardia. Okay, these are the P waves that get lumped onto the T wave because of the high rates. They kind of get melded in there. But those little bumps on top of the T wave are the P waves. Remember, the rate is going real fast. It kind of overlaps each other. But that is just normal supraventricular tachycardia. And what clues you into thinking this is supraventricular? Narrow QRS complexes. Okay, what's this? No, keep looking. What kind of paste? Both. This is atrial and ventricular paste. Okay? Do you see the pacer spikes preceding the P wave and a pacer spike preceding the QRS complex? This patient has sick sinus syndrome as well as complete heart block. There is no communication from top to bottom. So in this patient, this pacemaker is making their heart beat. Without this pacemaker, this guy's heart or patient's heart will not beat appropriately. So that's AV paced. What's doing here? What do you guys see weird about this one? P waves. So it's that wandering atrial pacemaker. Okay? Meaning there's a different foci giving that signal. It's not the SA node every time. Something else is sending off signals. Every time you see a different morphology, it's a different focus. Okay, so we see one here. There's one. Here's one. This one's a little deeper. Different areas, wandering atrial pacemaker. This is not all coming from the SA node. What's this? It's a normal finding. Don't think too much into it. Not a pause. Sinus arrhythmia, just from breathing. Okay, this is just sinus arrhythmia. Remember, as you breathe in and out, your heart rate changes. And you can detect it on an EKG if you're hooked up to it and you breathe. Now, what is this one? This is your sinus pause. So from here to here, there is no beating of the heart. There's no movement of blood. Nothing is happening. Okay, this you need a pacemaker for. Okay, because this is too long of a time without your intrinsic heart rate taking over. We need something artificially to sing the signal.
What's the cutoff for sinus pause? Like, how long does that be before you consider pausing on it?
I think it's greater than 2.5 seconds. So if you have greater than 2.5 seconds without a heartbeat, that's considered a significant cardiac pause. Okay, Cody, what's this one? Yes, why?
No P wave, wide QRS.
Yes, this is and actually the the P wave is right there. Do you guys see how that's a little bit different on that trailing end of that QRS complex? Because the P wave is there, because this is a junctional rhythm. Okay, so the beat starts here, it goes up, and it goes down. Starts in the middle and spreads outwards. That's what a junctional rhythm does. You can't see that in the back. Okay, lead association now. We're done with rhythms. Let's talk about leads now. Okay, so 2-3 and AVF is associated with which coronary artery? First of all, 2-3 AVF. What territory is that? Inferior. What blood supply feeds the inferior part of the heart? Right coronary artery. This is what I'm telling you. If you don't do this in order, you'll be all confused by this part. So you have to do it in order. V1, V2. What part of the heart is that looking at? Septal. What arteries feed the septal portion of the heart? LAD. V1 through V4 is looking at what part of the heart? Anterior part of the heart. What other vessel feeds the more anterior part of the heart? Here's your left anterior descending as well. Oh, left main was kind of both. But circumflex is for your lateral leads. Okay. Left main is that widowmaker because that feeds everything. And if that dies off, your LAD is gone, your circumflex is gone, your OMs are gone. You have a full-blown heart attack. Okay. So left main would be everything. All of that will be affected by a left main disease. Okay, we did this already. 2-3 AVF are inferior, septal, anterior, and lateral. We did that? Okay, 12 EKG. Now, pay attention to the colors as we go through these ones, because If it's a green worded answer, those types of EKG rhythms are okay. They're benign. They're not going to kill you. The blue ones are probably fine. You may need a cardiology workup to make sure everything's okay, but in a blue one, abnormal, but you'll probably be okay, but you still need a workup. If it's yellow, it's an urgent or semi-urgent. Patient will die or get worse if you don't do anything. And the red ones are the emergency ones. You have to do something now for these patients. Okay, what is this one? Asystole. Yep, and this is going to be red. Okay, ventricular standstill is another one. Yes, you have to do something or this patient's going to die. Okay, look at this one. Look at your rate. Look at your rhythm. What's the rate here? Is it fast or slow? Fast. We know we're tachy. Now let's look at the rate. Look at the P waves. Do you see a lot of P waves? No. Is the rate regular? Kinda. A little bit. Look at the bottom one. See how it changes up a little bit? Atrial fibrillation with rapid ventricular response. Rapid ventricular response because it's over 100. That's all that's referring to. You can have AFib with a slow ventricular response, that's less than 60. Or AFib with sustained ventricular response, which is just your normal 60 to 100. When AFib first starts, you're going to be very, very, very fast. But then over time, left untreated, the AV node gets bombarded so much it starts to slow down. And then the rates start to slow down because less impulses are getting through the AV node and the heart rate gets lower and lower and lower. When that happens with those AFibers, they're going to need a pacemaker very soon because their heart rate's going to get too low. Okay, what do you notice about this one? Start again, rate. Is Brady or tachy or normal? This is Brady. Okay. What else do you see? What about the rate, rhythm? Are there P waves? Are they before every QRS? Yes. How is the QRS? A little bit wide, but it's being pulled by the ST segment. What about the ST segment? What do you see about that? Where is it elevated? 2, 3 AVF, right? Which is indicative of what? Inferior wall MI. Okay. STEMI. ST elevation MI. Okay. You can also have non-STEMIs. A non-STEMI means you have a non-ST elevation MI. What has to be positive if you had a non-STEMI? Troponins. Your cardiac enzymes are elevated, meaning it shows that you have signs of heart damage, but there's no EKG changes. That's considered a non-STEMI. This is an inferior one. Okay, what's going on here? Of what? Why do you see left ventricle hypertrophy? And you have very, very, what is special about V2? That deep S wave, which is going to be the opposite for the left side of the heart. So yes, this is left ventricular hypertrophy, or a wandering atrial pacemaker in this one with left ventricular hypertrophy. But look at the P waves, guys, especially the bottom one. And then you have a pause here. No P wave there, no P wave there, no P wave there. That's why you have to do rate, rhythm, look at all the P waves, look at the QRSs and so forth. Keep looking. Now this one really sticks out as far as what it's going to be. This one's very obvious. This is a hypertrophy. Which one is it? What also tells you to believe this is left ventricular hypertrophy? Okay, very, very, very tall Q waves. We have T wave T wave strain, that inverted T wave from long-standing left ventricular hypertrophy. Also has third-degree AV block. You guys got to look at the P waves. You guys aren't looking. Now, on your quiz and your exam, you're going to have the answers in front of you. So if you see an answer that doesn't include yours, you're like, hey, I better look closely and see what else is there. At least you have the opportunity to have 4 answers in front of you, and the real EKG, you can figure it out. Okay, always look at everything. Yes, you will see other things there as well. Don't get confused by just the hypertrophy. You have to look at everything. Yeah.
Could you explain like right and left hypertrophy, like where we're supposed to?
Okay, so we'll use this one as an example. With right hypertrophy, you're going to have very tall R waves because the right ventricle has a lot of mass. It's going to have a lot of voltage. You're going to have on the septal part, V1, V2, which is right on top of the right ventricle. They're going to be enlarged. They're going to be very, very tall. You're going to have the opposite effect on the lateral leads because in relation to the right, it's a lot smaller. On the left side, this chamber is big now, so all that lead to, everything going to go there. You're going to see very, very, very big QRS complexes on the left because that's the lateral leads. So just remember, 5 and 6 are always going to be left. 1 and 2 are always right. If you see bunny ears in V1, V2, right bundle. If you see bunny ears in V5, V6, it's a left bundle. Yes?
Can't you also like add the deep S wave? And
Yes. You can add them together. That's in our criteria, yes. You can add them together. Okay. So the lesson is, yes, we all see that. But don't forget to look at the other things as well. Okay? Look at what's the rate here. This is right on the line. So 300, 150, 100. So we know our rate is less than 100. So our rate is normal. Look at P waves. How are the P waves? Are they the same in every beat? Yes. So we know the P waves are coming from the same spot. How are the QRSs? They're all the same. Is there a T wave after every QRS? Is it the same direction as the QRS? Yes, we know that's okay. Axis. How's the axis here? One is positive. That's equivocable, meaning kind of even, but a little bit more positive. This is a normal axis. Okay, AVF is okay. Lead 1 is okay. Both thumbs up. Axis is okay. ST segment. What changes do you see in the ST segment? A lot of ST elevation. 1, 2, and 3, and 4. And a little bit into 5. What kind of MI is this one? Anteroseptal. Meaning the anterior part, because you're getting more into 3 and 4. So it's more anterior. What is this? This is just VTAC. Okay. Monomorphic, those aren't changing twisting of the points. This is not torsades, this is monomorphic, one shape, VTAC. Okay, how's the rate? 300, 150, 100, 75. So our heart rate's okay. What about P waves? They're there. Are they before every QRS? How's the QRS complex? Is it? Do you guys see that delta wave sluggish in there? Does everyone see that sluggish delta wave going into the QRS? You do now. Okay, you got bunny ears. Yes, the bunny ears are there, but guys, do not let that distract you from the other answers that potentially could be in there. So always look at the answers and your quiz and your test before you do all this. Yes, this is a right bundle branch block. Does everyone see the right bundle? Because V1 and V2 are the major ones affected. That's the right side of the heart. 5 and 6 bunny ears is the left bundle branch block. What's the rate? Just find one on the line. If they're not on a line, just know this is like the second one. So 1, 300, 150, 100, 75. So between 75 and 100. Normal rate. Look at the rhythm. Do you see P waves before every QRS? How's the PR interval? Normal. Okay, and then constant. How's the QRS complex? Narrow, right? It's fine. Within 2 to 3 small boxes. How's the T wave? Does the T wave follow the QRS complex? Yes. Everything looks normal. Normal sinus rhythm. You have a question?
Oh, the T wave seemed tall.
No, that's fine. Okay. Yes, we all see this. Okay? But, and another pause right here. I may not ask you that question, what do you see? I may ask you, what's the axis on this question? What's the axis here? Okay, what's the axis? Normal axis. Both are thumbs up. We're good. Lead 1. AVF are positive. Both thumbs up. We're good. What's the rate on this one? 300, 150, 175. So rate's okay. What about QRS? Narrow and normal. QRS is okay. Okay, what's the answer for this one? Just a sinus pause. Everything else is okay, just that sinus pause. Does everyone see the pause? Okay. Actually, do the rest on your own. I want to give you time for the quiz. So